Perfect. Okay, welcome everybody. I am Callie. I am the Director of Marketing for Promises. And today we are back with our 2026 PBHU. I'm really excited. This is going into our third year of webinars every single month, offering you free CE trainings. And if you joined us last year, you may have recognized today we are back with Audrey Petty. She's our Director of Utilization Review here at Promises. And we're talking about ASAM 4. So we've talked about ASAM in the past, but today it's going to be really a deep dive into what that entails and what you all can learn and take away into your own practices. So you can go to the next slide, ma'am. Perfect. Okay. Audrey has over 25 years of experience in the mental health field. So while her focus has been on behavioral therapy, diagnostic assessment, crisis management, and individual counseling, her clinical work has also been spent 20 years of teaching full-time in both the community college and university settings. So she serves as a lecturer at Sam Houston State University and an adjunct professor at Blinn College in the Department of Psychology. In addition to her academic and clinical background, Audrey has 15 years of experience in administrative and leadership roles across acute psychiatric care, residential treatment, and community outpatient clinics. She has held positions including Director of Utilization Review, Director of Admissions, Clinical Director, and Consultant for Credentialing and Clinical Integrity. And as a leader, I can say that I know this about Audrey, that she is deeply committed to supporting our professional development and overall well-being of the teams that she leads. So as a clinician, she takes a compassionate and client-centered approach while creating a supportive environment that encourages healing, growth, and meaningful change. Really glad to have you back.
Thank you.
All right, let me introduce Promises a little bit to you all. I'm sure you all know Promises Behavioral Health. We are what is bringing you all these amazing clinicians every single month. So we have 7 locations across the country. We have 3 here in Texas. We have the Ranch, Tennessee, Ranch, Pennsylvania, Washburn House in Massachusetts, and then there's actually one more in Atlanta. The Promises Atlanta down in Georgia. So what I'd love to talk about to you guys about is our clinical integrity. As you know, we're really focused on building on our family programs this year. Everywhere you go, you'll have the same clinical excellence across each treatment center. To talk about the Ranch, Pennsylvania, they were on Newsweek's top treatment centers in 2025. Down in the Ranch, Tennessee, our flagship facility just outside of Nashville, where we offer equine therapy, only location that offers that, and then also a sexual recovery program for men that is in intimate and private settings where they can heal from sex and love addiction. Washburn House, they've been approved to now offer a 9-month stay when someone needs support. In Promises Brazos Valley, they were one of the first mental health programs in residential services within Texas that's offered at DFW now. So at Promises DFW and Promises Atlanta, those are our 2 newest locations that opened last year. And the Right Step Houston celebrated 35 years of service last year. So if you have any questions or would like to learn more about any of our programs, you can reach out to that email, pbhu@promises.com. That comes to me and my team so we can help you navigate any questions that you have around admissions or around just wanting more information on one of our particular programs. We offer telehealth services, PHP, IOP, mental health and addiction residential across the board. So let me know if you need anything, especially for this weekend as we come into this inclement weather. We are open. We are here for you. If you know anyone that you're worried about being isolated, you know, we are here for those people that need that support. So you can reach out to me there at pbhupromises.com, or you can send a direct message to me in the chat and I can send you over any information that you need there. You can go to the next slide. Okay, yes, I know you're all here for C's. So if you're already here, you're in the right place. There's just a few things that I want you to know. Um, Looks like I updated this slide recently, and I may have forgotten to update a few of my languages. So listen to what I'm saying. Don't fully read this slide. Um, if you are here, you are in the right place. So at the end of the webinar, you'll get an email from the CEO company, the same group that you got the attendee link to. That will send you an email to fill out the survey. So when you fill out the survey, from CE Go, they automatically send you your certificate. It's not through Jotform anymore. We know this as of last year, that has changed. I also want to remind you that if you are here with like your clinical team, you all need to be using separate devices. So the link that you registered on, that you clicked into to come into this Zoom room today, that is your sign-in sheet. So if you are sharing a computer with a colleague, only one of you is signed in here. So you can be on your computer and your phone, you can switch back and forth. Just make sure you are separate from your colleagues in that way. Once you receive the certificate at the end, it goes into your attendee dashboard. So hopefully by the end of 2026, as you experience in 2025, all your certificates, your evals are going to be saved for you in your dashboard. Oh, and then just as a reminder, slides, resources that Audrey mentions today, we'll get those out to you next week. The recording will be up on our YouTube channel later today. Okay, and go to the next slide. All right, during the webinar, chat box, as you can tell, it's open. We've updated this so it's not just going to me anymore. I would love for you all to be able to have those conversations on the side. Just keep it to a minimum. As you know, you're all here to learn, so try not to make that overly busy. If you need anything regarding technology, webinar functions, CEs, you can find me in the chat. Where it says that to field, you can change it from everyone to just me. And let's keep the Q&A dedicated for questions to Audrey. So that way when she comes back after the break and at the end to answer your questions, she can just look in that Q&A section, and that's where you'll have questions for her regarding the content. Okay. Next month with PBHU. Okay, so next month, February 27th, we have two speakers, Ashley Martinez and Kristen Collins. They're both from the Ranch, Tennessee, and they'll be speaking on family engagement. And so one of our pillars of promises is talking about the family programs that we offer. So I'm excited to reintroduce that program to you next month and also have them speak about recovery capital and family engagement and residential treatment. That program is truly one of the best that we offer, and I'm really excited for you all to meet them and hear more about it. Okay, you can go, and I'll also drop the registration link to that before we get started here. Okay, Audrey, take it away. Thanks,
Perfect.
y'all.
Okay, we're going to do a quick overview. Most of you already kind of know the first two slides that we're going to review. Essentially, ASAM is the most widely used criteria. It's just a set of standards that we use to basically drive care. What are these patients? What are the patient's needs? What programs should we put them in? And it's almost as if it's a governing board. You feel that way, but it isn't. It's really just some guidelines that we all use. But the reason it feels that way is because we have over 30 states that have actually adopted this system, and our payers have adopted this system. So remember, it is just a tool to be used really by the clinicians, our payers, policymakers, and even other stakeholders to help us guide treatment. Otherwise, we'd kind of historically, the mental health field has kind of gone off the rails many times in the sense of just kind of, oh, you need treatment, you do this, or we want you in here, whether somebody met the guidelines or truly needed it. And there was no formal process to actually make sure we're meeting the needs of their patients, to see that they were getting the actual treatment that was best for them. Here are some people who are actually using this. We just kind of talked about who's using it, clinicians, providers, insurance companies. Who are those providers? Outpatient settings? Any clinician, therapist, psychiatrist, psychologist, social worker in an outpatient setting you can use ASAM. Intensive outpatient settings. So that's your IOP and previously known as PHP, and we'll go over the new name here. And then, of course, residential, inpatient facilities, and community-based programs. The stickler is our payers are using this. So they have their own interpretation, their guidelines that ASAM is given. And then if you are in the utilization review or a clinician that's had to do a peer review, you realize our interpretation of what a need is very different than their interpretation. But here are a couple of the payers that are actually using it. Now, Optum I listed first because they were very helpful in establishing the new ASAM criteria for ASAM 4. They were one of the first people trying it out. They were in all the conversations. So as the underwriters are doing their research and gathering information to sharpen up ASAM 4, they were right there with them helping kind of carve out the guidelines. Aetna's using them. Interesting enough, Blue Cross Blue Shield, I always thought that they were just using MCG guidelines. They have a few that are actually using ASAM in conjunction with MCG guidelines. Aetna always talks about how they use them in an intertwined process. They try to use MCG guidelines and ASAM, but I don't think Blue Cross Blue Shield has ever verbally said that to me on a phone call. So if any of you've ever had that experience, great, because Blue Cross Blue Shield of Illinois just recently started the conversation when they're asking for our ASAM criteria, but also our ASAM license. Texas, Oklahoma, New Mexico, and Montana are the Blue Cross Blue Shield um, products that are actually using ASAM in conjunction with that. Evernorth has been very vocal that they're utilizing it. They have great resources on their website for how they're grabbing it and what they're kind of, they use the ASAM criteria and then they talk about how they're going to use that to define medical necessity. So they're very helpful. The Centene Company, both their products, and they have a couple of others, but Ambetter and Superior, I'm just kind of listing the more popular insurances, are actually asking for your rating scales and they want it on paper. So if you were working with insurance companies or in the utilization review department or a clinician doing a peer review, 3 years ago, they were just asking kind of verbally, give me your ASAM score. Now they're wanting the hard copies. They want to know what your clinicians and your physicians have rated them and the dimensions and the subdimensions. If any of you are in Massachusetts, your MBHP is using it. They are getting a little tougher. They usually weren't as strict with like wanting the criteria with the documentation, but now they're doing that. So just be aware as you're providing the documentation and making sure if anything you've learned about ASAM that you're getting it into your notes. And then there are many other Medicaid products that are using it because most states are adopting the ASAM. Let me get to my next slide. So what were the goals of the ASAM updates? Well, one, they were trying to make updates based on current research, new literature, information that they've gathered from facilities and clinicians, and kind of make a standard reflective practice. So they want to standardize everything, and this is their goal in getting that there. They also wanted to promote that chronic care model. They want to make that continuity of care seamless. They want to make sure you can go from one level of care to the next and then possibly go back up if you need to without any problems. But they're also, if they make it seamless and they get you through each level of care, they're hoping that you're not coming right back and then you're utilizing kind of those residential support services as well. And we'll see that when we get to that slide. Person-centered, holistic, integrated care. So yes, we were supposed to be that way the whole time that we've been practicing, but they didn't spell it out for you. And now they're really doing that. They want the patient's involvement. They are going to ask in the beginning what I think most facilities have always asked, what level of care are you interested in? Now we're going to gather the information and they want us to ask, okay, what do you think you fit into? And here is what we feel you meet and work with them together. Someone may want detox, but they may not have utilized a substance for 6 or 7 months, yet they have some psychological criteria that may help them need some withdrawal management because we're looking at the psychological factors as well, but you don't necessarily need to go to detox now. You can do that at other levels of care. And supporting kind of the simplicity of it, getting that common language, giving us levels of effective ways to implement the levels of care. So that was their main goal in making the changes for ASAM 4, the criteria. What do we use this for? So everybody talks about ASAM. I think interesting enough, that Callie mentioned, I've been working in this field for many years. I never was exposed to ASAM. I knew about the Blue Book because you kind of get sprinkles of that in your education, and you as you're practicing an outpatient, unless you're specifically working with rehabilitation, you don't get much into it. However, I had a little sprinkle. I knew what the good blue book was. I knew there were stages and steps, but I really didn't know the depths of it until coming to work for Promises. So my expertise in this area kind of delved in. I think the first product I had was the ASAM book that was delivered to me on my desk on my first day of work and said, "Hey, start reading this." And luckily, it was a good read. But what are we using the criteria for? We want to evaluate what are their patient's needs? What do we do? What is going on with your patient, your client at this time? And then determine the appropriate level of care. And we're going to kind of get deeper into that. And then as we've determined that appropriate level of care, are we making our treatment individualized? And we all know, we have certain tools, we have um, theories and ideologies that we utilize, and they're broad, so sometimes they don't feel extremely specialized or individualized. But our goal is to make sure this patient feels special and feels important enough that their needs are being met. So we have to bring that in to our treatment plans and some of the things that we're talking about in their groups and in their individual sessions. So we're creating that treatment plan. We're gonna use outcome driven means of measuring treatment, and this is a big push for ASAM-4. I would say that it has always been a part of the process, but they're really pulling in, and you'll know that you guys should be using different measures to measure levels of anxiety, depression, cravings. Your payers are specifically asking for that, for the criteria that is driven. I want to keep saying income driven, but outcome driven. So if I mess up with that, I apologize. And then essentially, we know that we want to meet medical necessity. We want to see and provide enough information to our providers, to the insurance providers, so that they will cover their clients. The last thing a client wants to hear when they're in treatment is, "I'm sorry, your insurance isn't covering, you're not meeting medical necessity, and here's what we think you still need to work on, or here's what level of care we think you're appropriate in," when that client really is enjoying the work they're doing at the current level that they're at, and they're really not emotionally ready. Sometimes we've got to use our motivational interviewing to make them realize they are. It's just scary to make the next step, but sometimes they're not. But we, as clinicians and providers, need to make sure we're documenting the importance and the impairments and the goals that the clients do need to continue to work on to keep them at the level of care and have it covered. So the bill could just be a trigger for, I mean, it's a trigger for me. When I go to the hospital and see the bill, I I have a mini heart attack. I know that these clients who are struggling to use their appropriate coping skills and manage those triggers, that's just a big one for them as well. So it is part of our responsibility as clinicians to deliver the product, help that client evaluate, deliver the product, but also document that we're delivering the product. Most of us in this field, all of us, really not just most of us, all of us working in this field got into the field to help people. And we feel good when we're helping them. And yet, that is the one piece that I do know we're not taught, is how to document the good work that we're doing. We're taught all the ideologies, we're taught how to deliver the product, we're even taught how to write a treatment plan, but we're really not taught how to write those notes so this patient stays covered. All right, so levels of care. We're going to go over the levels of care. You all kind of know or have been exposed to them. They haven't changed that much, but they've kind of changed. So a level 4 inpatient stay is utilizing a complete medical background. So you are going to be acute care with medical involved, or standalone medical where you're focusing on detox. So you're really going to be more focused on the physiological responses and withdrawal symptoms that your clients are experiencing, you're going to use some of the psychological and have the mental health and the rehab component, but these are for the patients who are really struggling um, with the physiological symptoms and had a hard time previously. So residential, we've divided up into three, so they were there. We've got medically managed residential. And so if you're used to the word detox, that's your normal detox. Most of our payers and ASAM has really talked about it. Residential, use the words residential detox, but now the common language that they want us all to speak is it's medically managed. It'll be more difficult for our clientele to start adopting this because when they come in and they're using their substances and they're having a hard time and they need to quit, for whatever reason they're ready for, they use the word detox. So we still have to accept the word, but we do need to start exposing this to medically managed residential. It's going to have the biological component and the co-occurring component. It's just the language that changed, and it's very hard for us as practitioners to change, but the whole point is that common language. So they're getting there. We're pushing it. So hopefully, 5 years down the road, when they don't make changes for that long, and we get to 6, we're all kind of adopted that language. And then your clinically managed high intensity, this is your RTC, your residential. And I'm going to break them down and kind of show you what is needed in a couple of slides going forward. And then the clinically managed low intensity, this is still a residential, but they're not necessarily needing the 24-hour medical care or the nursing care like you do at the other 2 levels of care at residential. This is really clinically and therapist driven. Our outpatient. So this is a big change for us. We have the medically managed intensive outpatient with co-occurring. So this is, you have physicians involved, you have nursing involved, and it is more intense than in these 2 levels of care because you have that daily care as well, but it's an intensive outpatient. The high intensity outpatient is now called HIOP. Previously, it was your PHP programs. So that's another language that we're going to have to shift to. Our payers are already somewhat using it. Depending on the reviewers that you're working with, they may use PHP, they may say HIOP. The goal is to get us all on the same page, but remember your clients are gonna be requesting PHP and they're gonna use the term PHP. Here you can have the co-occurring, so we can have mental health integrated. You should have mental health integrated at all levels. I'm trying to move your visa, sorry. However, that wasn't necessarily historically what people assumed you were getting. Um, there have been 2 schools of thoughts throughout the continuum of care with substance abuse, is that they're 2 separate things. Yet now ASAM is trying to integrate them more in a formal matter where we've all kind of known that they've been integrated. So we are well aware that a lot of our programs, we're going to work on the mental health as well as the substance use because they're intertwined. It's kind of that old age debate with nature nurture. It's the same thing within the substance world, mental health versus substance abuse, and how those diseases kind of intertwined together have been a debate historically. ASAM level 2.1 IOP didn't change names, kind of stayed the same. We're still below these 2 other levels of care. And then our level 1 outpatient. So we can do medically managed outpatient. So you're going to probably incorporate a psychiatrist during this time. You may be working with co-occurring issues as well. Outpatient will do the same thing. Most of the time, we're going to be referring them to. So if I'm an individual, some states, state of Louisiana, you've got a few psychologists that may have been grandfathered in and can prescribe medicine. So they may be working at either one of these levels of care. And then long-term residential or readmission monitoring as well. And then we have the RR recovery residents. level of care, and this is their continuum. They're hoping when we are assessing someone, we're starting at the lowest level to see, the least restrictive environment, yet not always trying to push the top, but making sure we are meeting what we need to do. Okay, so here we are, levels. Wait, I went backwards. I apologize. So we're going to start out with our medically managed levels of care. So that is going to be, of course, your level 4, medically managed inpatient treatment, 3.7, our old residential detox, medically managed residential treatment, 2.7, that medically managed intensive outpatient, and 1.7, that medically managed outpatient treatment. Here I've kind of broken them down for you. What does all that mean? What are we supposed to be doing? So if you look at the level 4, you need that 24-hour supervision. They shouldn't be going off-site unless they have supervision with them. You need a medical director. You typically need someone available on site 24/7. So you've got nurses, you've got physicians, and reachable physicians, because we all know we're not a major medical hospital, so we don't have physicians spending the night with us, but typically they are available for a phone call. But the nursing staff is there. Here is your nursing available 24/7. Program director, it's variable because you may not need one, you may need one because you've got so many other staff members probably taking over that role. And allied health. So typically available. We need to be able to draw blood. We need to be able to help. And allied health would incorporate your BHT staff members as well if you're at that ASAM level 4. Nursing assessment, due at admission. They're spelling it out for you. They want you to get that done at admission. Most of our payers are requesting that information at admission. Even the silly ones that request a prior authorization, I need to give you permission before they come. They still want vitals. We still need the information from the nurses. Typically, some of us have vitals machines at home. We're taking our blood pressure if we have those conditions that we're worried about. But most of our clientele, they're not having a pulse ox and a blood pressure machine readily available. So we can't really get some of that information. And we can kind of assess a CALS, but really, or a CWAL, but sometimes those scores, most of the time, we need a visual for those. The clinical services that are needed at level 4, direct withdrawal management, the biomedical services. So we want medication management, psychiatric services, and we definitely want psychosocial services. So we want our therapists there. Oh, I'm sorry, I'm trying to move. For you, you may not be able to see that, but I can't see myself. I can't see that bottom. I know that it's funny. I can't move it. We're going to minimize it.
Do you want me to read it for you?
Maybe.
I don't see
Because I
anything under
covered it.
recovery support services is a lot.
And
Is
it
all.
is 20 more hours of clinical services, right? 20 or more every week. Is that under, like, it's hidden from me, so I apologize.
Yeah, the first one says 9, and then the other next two are 20, and then the last one
And
for
level 4 is 20. Okay, perfect. I just wanted to make sure I wasn't mistakenly remembering that by memory. All right, so 3.7, that is your medically managed detox. So the term that we're using old school was detox. Now we've got medically managed residential treatment. You got 24-hour supervision. So remember, these patients aren't allowed off site. Your payers aren't going to accept that. ASAM is not approving that unless there's someone with them. So sometimes historically, we've sent patients out to go see their neurologist or a cardiologist. Somebody from your staff is expected to travel with this patient. 24-hour supervision is 24-hour supervision. So if you allow this patient out, then guess what your payers are going to think? Oh, they went to a funeral, or they went to the doctor alone. I think they're ready for the next level of care, even though we know this client isn't, and maybe you could have trusted them to get there and not use their, that's something that if you want that continued care at that level of care, you've got to completely provide that level of care 24 hours a day while they're paying you for that service. Again, same thing. physicians available, nursing staff available. You are going to need a program director here because remember, we're going to incorporate more of um, our psychological services. The allied help is typically available. The physical exam, I forgot to mention that, both of these levels of care within 24 hours. So that's your H&P. At admission nursing assessment, the clinical services are the exact same as they were for level 4, and we are expecting 20 hours of clinical hours and therapeutic services a week um, to be broken down through that week. And then also recovery services are available. That medically managed intensive outpatient, you don't need the 24-hour supervision. We do need a medical director. You can have physicians available via telehealth or on site, so there's some flexibility there. Nursing available, program director available, allied health available if needed. Some of us utilize, we contract those services for people to come, and they are available when we have whatever our contract says. And some facilities, I've worked for a facility where we had these people on staff, so they were there 24 hours a day. That physical exam is due within 24 to 48 hours of that initial assessment, which would be that nursing assessment at admission, same clinical program, same hours of expectation and recovery services. The medically managed outpatient, very few of us, if you're an outpatient client, you are therapist provider, you might be providing this service. Supervision, we don't need it 24 hours. You do need a medical director if you're that medically managed. So you could be a clinic where you have therapists and a psychiatrist or a physician overseeing everything. So you're all kind of working with them. It's variable when they're available because it's usually by appointment. Nursing is usually variable as well by appointment because you're still going to get vitals when they're seeing that physician. Program director, not necessarily needed, mainly because the therapist is driving that program. The therapist and the client is going to do that. And they do want that physical assessment. If you're providing any sort of medically managed care, a physical assessment is needed. Same clinical hours or services to be provided, yet this is where you see the hours drop. They're expecting about 9 hours a week if you're going to be doing medically managed outpatient. So that would include your psychiatrist visit or H&P visit. That would include your nursing visit or a group or an individual session, as well as your therapeutic services. So that is a breakdown of the medically managed levels of care. Here we've moved on to the residential levels of care. They incorporate the 3.1, 3.5. 3.5 just has a little breakdown, but it's all the same. So you have the clinically managed high intensity residential treatment, and then you can have the same residential treatment with co-occurring. So it could be a dual program. 3.7 is here as well, but these should not be in there. I should have deleted those. Sorry. All right, so I broke down the clinically managed levels of care as well. So we've got that 3.5, that clinically managed high intensity residential care. So that is really what we call, or we have all been used to calling residential treatment. But look what we don't know. I think this is also something that very many of us have been confused about. It's still requiring 24-hour supervision. These clients aren't allowed off-site unless somebody from your staff is with them. We have eyes on them. Your payers are expecting this. Same thing would happen if this person were given a hiatus or a leave or a break or had to go to a doctor's appointment. If a member of your staff isn't with them, they're saying they managed, and maybe they won't. I mean, unfortunately, most of our patients, I think historically people have let individuals off-site, and they may have used, they may not have, because they went directly to where they needed to go and came right back. But the payer is going to say, well, they made it, so they're ready for the next level of care. So you have that happen, and then boom, your client really isn't ready for the next level of care, but the insurance is saying, yes, they are, and you allowed that, so then you have documentation of that as well. With the residential treatment, you do need that medical director. They need to be available. We want them to review admissions. So you should be asking for insight, hey, what level of care should this person be in? You should be reviewing that. So most of the time it's your nursing staff, or they've received an email with all the documents that your admission staff has sent to them, and then they've communicated with the nursing staff at some point. The nursing assessment is still needed at admission. Program director, we still need that. Allied health, either on site or alert 24/7. So if needed, some residential treatment centers have contracts with local ERs, which are right there, so they can send them to get their blood work and come back. Some of them have contracts with outpatient providers who will come to them. And believe it or not, they typically have, like Quest has people, some Quest services in bigger cities will have people on site 24 hours for if they're needed. All right, that physical exam is due within 72 hours. Most of the promises site we get that H&P done within 24 hours, because then that helps satisfy everything for us. The clinical services are also direct psychosocial services. We've got a high intensity milieu, and we are expected to provide 20 hours of therapeutic services, those clinical services, 7 days a week. The clinically managed low intensity residential services. This is a step down from that residential. It's still a residential treatment center. It seems a little bit like PHP as well, like it has a cross with it, but it's more of maybe group homes, maybe a residential setting that has a next step lower level. Some of your SOAP programs may be like this if you were in Massachusetts. You can leave. You have accountability checks. So what that really means is that person's going to go off site, go do whatever they need to do, family event, doctor's appointment, work. They're coming back, and the accountability checks are your your payers are going to expect drug tests. Hey, did you breathalyze them? Did you get a new a UDS on them? Do we have that information now? Not typically do you have these things, but clinical staff can do a breathalyzer and a UDS, a quick one. They have a little cute little kits now that are easy to use. You do have a program director. Allied Health is available or on site. That physical exam is due within 14 hours of admission, 14 days of admission, sorry. And we still have the same clinical services expectations, but the hours have now dropped. We are going anywhere between 9 to 19 hours a week, 7 days a week. And we do have the RS services available if needed. Here's your old PHP, the high intensity outpatient. We don't necessarily need 24-hour supervision. Some of us have that because if you have the programs with housing, you're keeping track of them. They're still your responsibility because they're living on your site. So there's some liability there. However, they can go to the store if they want to. They should be able to. You still have a medical director. You have medical staff available. You have nursing. That nursing assessment is due at admission. You have a program director. Allied Health is still available because you're still gathering all this information. Physical exam within 7 days, so that H&P is due. Now, granted, these are ASAM expectations. These are not your payers' expectations, because I'm going to tell you, most of your payers are expecting this within 24 hours. We want that H&P on admission. We want your nursing assessment done. We want it done within 24 hours. We want our psych evals within 24 hours. So please remember when you're going forward that although your state may have a particular requirement and ASAM has this particular requirement, your payers have more specific, tighter requirements. So be sure to read your contracts, because most of your payers, I'm here to tell you, I've read most of ours, they're expecting this within 24 hours. So you've got to meet who's going to pay for you, provide you this monetary support. And in order to meet medical necessity, these are the things they're wanting, because they're going to need that information. The hours for this high intensity outpatient, 20 hours a week. That's not a different expectation from one when it was called PHP, same thing. It typically can be 5 hours, I mean 5 days a week. I know some programs are moving to 7, but be sure to look at your contracts because those again specify the days of the week that you can utilize. And then 2.1, your intensive outpatient. So this is your IOP. You don't need supervision. You don't need a medical physician. If you do, you're using the other high intensity IOP. Nursing services not necessarily needed. You don't need the nursing assessment. Program directors, you do need. Um, we do still need data collected if needed, so we want them typically available. Physical exam within 14 days. Therapeutic program stays the same. And then your clinical services. Most people just believe IOP just needs to be 9 hours a week, but it can range up to higher. So if you're providing more, yay for you, you're going above and beyond, but the minimal expectation is the 9 hours a week. And then you do use the recovery services. Here are outpatient levels of care. I kind of just broke them down for you. We just went through the IOP, PHIOP program. Your long-term outpatient, you've got that long-term remission monitoring, outpatient therapy, medically managed. I believe I have another slide and I did break these down for you. So your 1.7, 1.5, 1.0 give you this same thing. So your 1.7, remember we want that medical director. Um, you don't necessarily need nursing staff. Most people will provide that because physicians love to have nursing staff accompany them in their work. Physical exam is typically needed at initial assessment. Nursing assessment, again, is variable depending on the program that you're working with or where they're getting their services. You still need to get the 9 hours, greater than 9 hours a week. Our outpatient therapy, you see, you typically have a clinical director providing services. You need a physical exam. So for our outpatient therapists that are providing ASAM level of care, remember, you're going to need to work in conjunction with their PCPs. You're going to want to know when their last physical exam is. Treating the whole person is treating the whole person. Someone may be riddled with anxiety, but we have tachycardia, or we have high blood, other high cardiac issues and high blood pressure. Or liver disease that may cause a lot of the same symptoms of anxiety. And so you want to make sure that's being treated so you can work on the psychological component of that as well. And then, of course, it's direct services because you're working one-on-one with your patient. You can do more hours. Now, be sure if you're providing outpatient services that your documentation is still proving medical necessity. Payers don't just ask for records from facilities, they ask for records from outpatient therapists. They're going to ask, we're providing this service. They don't always ask right away. Most of the facilities have to give documentation at each time they review, and they only give X amount of days. You are a little bit freer with outpatient because somebody may have 30 days within a 6-month period to utilize therapeutic services in an outpatient setting, yet they can still ask you for that documentation. Some of us have had experience of that, some of us haven't, but just know it's always there. And the clawbacks that they give, if they don't think your notes prove that you were providing what you said that you were providing, they don't ask permission, they just take the money back. And so then sometimes they don't even tell you. It's just there. And then you get the letter afterwards. It's just gone. The money's gone and then you get the letter afterwards. So, in long-term remission monitoring, you don't necessarily need any of the medical staff or a program director. You do need to verify that you've got that physical exam within the last year. Recovery remission services. So you're providing some therapeutic services. And then you're wanting to do this check-in. So we are doing check-ins. So maybe you're going to meet with this patient. Maybe they were here and they've been doing so well. You've moved them to once a quarter. You went from twice a week to once a week to once a month to once every other month and to once a quarter. So minimum services, you're seeing somebody for once a quarter during this time. Here's our patient's journey as we're going through, and we're going to get into the ASAM dimensions now. But right after this slide, I will let you have a break. But essentially, when a person is ready for treatment, ASAM is specified. We're starting that ASAM assessment at that first phone call. We're going to start gathering information. You may not start the assessment itself, but you're getting some background information. So when they're coming to treatment, before you're deciding what level of care they're going in, you are getting the information you need for the dimensional criteria. So you have the evidence-based protocol to say which level of care they're meeting into. And then as we're going through that continuum care, we start the treatment planning. And then while you're in treatment, you don't just have one treatment plan and boom, you're gone. Most of the clinicians who work in inpatient settings know they're constantly evolving that treatment plan. They're constantly reassessing. So typically your ASAM assessment is done within every 7 days because you're seeing where their what needs they still have, where have they come up, what have they achieved, and what you still need to work on. And then when we're ready for discharge planning, we're getting them ready for that transition. But just remember, you're not just waiting until day 54 while you're in a facility. You're starting that plan. Hey, we know what your needs are. We're figuring out what you like, but one of our dimensional criteria is looking at that home setting and what that next level of care is going to be. So discharge planning does really start at admission. All right, so before we go to the dimensions, I'll let you have a quick little break. Um, Callie, we will do, what do you think, Callie, 5 or 10 minutes?
Oh, I think 5 minutes is good.
Okay,
Yeah.
so give you a 5 minute break. So if you've got, well, really kind of six, I'll give you till 9:55 and if you're in Central Time Zone, and or 10:55 and you're Eastern. And if you're somewhere else, just be back in 6 minutes. To answer a couple of Hello, I'm going to answer some of the questions in the chat. So the insurance companies like MBHP are just insurance companies in Massachusetts. So depending on what state you're in, those are products in other states. Um, Not necessarily, if you're in Texas, they're not Texas providers. Another example of 2.7, let me go back and think of this. So I'm looking at it right. Believe it or not, my brain still has to look at the level of care before I talk about it. So 2.7 is our medically managed intensive outpatient. So that is your old PHP. So any partial hospitalization. So essentially most of your payers and the product itself is you're providing the same clinical care and medical observation than that you were while they were in residential. However, it's a step down. So now they don't need that supervision all the time. They're able to go out and apply their skills. So you've taught them what they need to know to get to the next level of care, yet they still need support and guidance. But we want to say, hey, go to your group or go to this family event or go out into the community and try to apply those skills. And then you're coming back to group to talk about it, whatever struggles or what things you need to work on. So you're still getting that support while you're starting to adventure into the world to apply those skills. I hope that helps, Diane. You're right, 2.5 does seem, why is 200 a little lower level of care? So let's go to 2.5. Oh, that's our outpatient again. That's our PHP. Essentially, it's going to be more intensive because you can go out, if that makes sense. So it's as if you're And most people who are in an HIOP aren't housed, but some programs like Promises has a couple of programs where they can do the HIOP with housing. Um, Essentially, it's weird. Um, and right now, I don't know what the payer expectations are really for 3.1. I need to read up on that because we don't have 3.1 where I work with Promises. We have only 2.5 and the IOP program. So we do the 3.7, 3.5, 2.5, and 2.1, and then our Massachusetts facility has the RRS in different programs. But the interesting part of that is learning more. I don't know if I've ever come across a contract that had the 3.1. So I believe that's why I thought it was more of an outpatient setting, like a group home type environment where you're still following those programs. But it is something I definitely need to explore more. The whole point of the physical exam is that you're working um, getting that information probably from their outpatient provider, and they want you, the whole point is to make everything seamless with the continuum of care. And if you've monitored medical, they're also stepping that down. So they want to make sure that you're collaborating with other providers. So even if they were in family therapy, they'd probably want that as well. But with the physical exam, they know that you've collaborated. So that's why they're asking for that documentation. The weird thing is that you can't provide that to your payers, but I'm assuming ASAM is wanting to make sure that you're doing the checks and balances and getting that. And a physical exam would be any type of physical. So yes, a doctor or a nurse can do that depending on, and most of the time if you're going to your PCP, it's going to be a nurse practitioner or a PA doing that. Interesting question, Kristen. I think I'm going to have to get back um, to you on that because I'm going to have to read. So 3.3 LOC is not being reviewed. I know A 7.5 did not include it, but we're reviewing ASAM 4, if at all. I have to ask permission to get back to you on that one because I gotta think deeper with that one. Okay, I'll answer the rest of the questions after. I don't know how to get rid of the chat. I'll close it so we can get back to our program and not get over on our time. So the dimensions within ASAM 4. Dimension 1, intoxication, withdrawal, addiction medicine needs. Dimension 2, the biomedical conditions. Dimension 3, psychiatric cognitive. Dimension 4, substance use related risks. 5, that recovery environment interactions. And then 6, which is our person centered. With these dimensions, you will hear the terms dimensional drivers, subdimensional drivers. The word driver really just means criteria. What is supporting that or not supporting this level of care? So when you look at dimension 1, you've got your subdimensions, dimension 2. And so if you'll notice, there's a trend here with these subdimensions being in blue. And under biomedical conditions, you've got 2 subdimensions that are blue. They're blue for a reason. They're blue because those are the only subdimensions that you're actually rating. You're going to rate those in their assessment tool. And I'll break that down for you guys. We'll have a slide on that. But when you're giving a rating score, you're rating these 3. You're rating this. You're incorporating sleep problems into the rating, but it doesn't get a rating all in itself. And the same thing for the differences with the subdimensions that are typed in black versus the ones that are typed in blue. You're rating those. All right, so the whole point and their purpose is that we are using the dimensional admission criteria. We're going to apply the admission criteria. We're going to assess our risk. We're going to rate each dimension. Then we're going to apply all that we've learned um, from dimensions 1 through 5 to figure out what level of care we're going to get. So they're wanting to provide basically like a little tracer of how you came to the conclusion that this level of care is what this client's needs. Not necessarily somebody showing up and then we're starting to gather evidence after we put you in detox or after we put you in residential. They want all the proof right at admission. They want it right then and there. And they want to show that all the parties responsible have had some input. The client, the physicians, the therapist, your admission staff. And then with number 3, step 3, we're reviewing those dimensional considerations, characteristics for dimension 6 to really extra support that level of care decision that we've made. So with dimension 1, what we have is intoxication, withdrawal, and addiction medicine needs. With intoxication and associated risks, you're looking at those acute risks. We are really trying to figure out what those biomedical symptoms they're having. So we're not necessarily providing meds, but we're looking at the physiological symptoms that someone is experiencing by either being intoxicated or slowly unintoxicated based on how they were intoxicated before. And do they need which interventions are they going to need? All 3, biomedical, psychiatric, and intoxication interactions. Like, what are those interactions going to be with those 2 criterion with how intoxicated they are? And do those symptoms require 24-hour care? With withdrawal risks, we are going to proactively assist their withdrawal. Also take into consideration whatever comorbidity. So someone with anxiety going through withdrawal, physiological withdrawal, may have heightened senses. They may have our mind and body are intertwined. So if we are expecting to have more withdrawal symptoms or we're fearing that, it's going to exacerbate some of our feelings. Our heart rate's going to increase. Our nervous system kind of goes into that fight or flight and we get into that alarm stage. So it can, the interaction of the 2 can create a bigger problem for the client. What this means is considering anticipated withdrawal syndrome. What was their history like? What do we think they're gonna start experiencing? They may be detoxing off of benzos, or they want to detox off of benzos, or even alcohol, but they're not having any withdrawal symptoms right now because they're intoxicated. But we know they're going to give them 24 hours without this substance and they're going to have that. So what are we expecting this patient to start feeling within the next 24 to 72 hours? And how are we going to document that the person's particular needs? And then the recency of use. This is a very important thing to remember. Recency of use does not eliminate the need for treatment. When I first started working in the mental health field, I'd hear a lot of people say, "Oh, well, you need to be using to get into treatment." No, you may not have used for a couple of months or a couple of days, but you may still need treatment. And it's all about the questions we're asking you. What are your needs? What are you experiencing and what do we think you're going to experience based on this? And some of these questions can be asked while we're got you on the phone to grab things because we can start figuring out what symptoms you do experience because perhaps, and a lot of us have spoken to a client while they're sober and they're going through withdrawal, but by the time they get to us, they're no longer sober because just to get to us, they needed a couple of drinks or they needed to utilize the substance that they're using. So we want to ask the questions like, what are your withdrawal symptoms right now? Are you shaky? Are you trembling? Are you hungry? When was your last meal? When was your last use? Because if it had been 24 hours, you may be feeling symptoms, but by the time you show up, you don't have any symptoms because you used again. So we want to make sure we're counting this in the recency of use. And then what was their responses to treatment historically and right now? Because some of us go to treatment because somebody else wants us to go, and we're just doing it because we need to maybe not go to jail, maybe for our spouse not to leave us, maybe not to lose our kids, but we really don't want to get sober. So what is our responsiveness to this? Why are we there? And then our needs for addiction medication. We're not just looking at MOUD. So we're not just looking at medicines that help titrate you from um, using methamphetamines or something else. We're looking at the initiation or the titration of certain meds to get you safely out of your addiction. So we need to get you to a safe spot in your withdrawal. And so we're going to be looking at the need for titration, the need for medications to help with your withdrawal symptoms, and then what are those interactions with continuing certain meds if you're withdrawing from several medications. And then what is your access to this? So we do need to ask this right here. Post-discharge, if you're using a medication that's helping you withdraw and manage those withdrawal symptoms, and it's a longer titration than you need while you're in the hospital, or it's a maintenance dose that you're going to have for a long time. What is your access to that? Because that's going to help us understand where we're going with discharge planning. What are we going to need? Because if you have no access and you live super remotely, or you're paying cash and for this stay, but you can't get it, we need to help kind of figure out how we can get you to that next stage as well. With Dimension 1, we need to make sure we're getting the hard evidence that our payers want, that provide the importance for proving the level of care, but also medical necessity. So our patients aren't coming here for absolutely no reason. Because if we're not getting the things we need to prove medical necessity, to prove that our patients are in dire need, they're at risk for their payers, insurance providers not to pay. And that is just going to be a strike. So all they need to hear is like, oh, you don't meet criteria, then boom, they're already hopeless. We don't want to give them any more reason to be hopeless. So with that, we need to make sure we get those vitals. We need to make sure we get the breathalyzer. We get the drug screening. We're gathering the data, the information about their SUD use, so substance use historically and current. And we need to do a CWA or CALS. And let's say someone does not qualify for a CWA or CALS because they were not using alcohol or a benzodiazepine. There are pause symptoms that you can ask questions about, because remember, we're looking at two types of withdrawal. We're looking at physiological withdrawal and psychological withdrawal. And some of those symptoms are pacing. Some of them are depression. Some of them are extreme fatigue, difficulty remembering things, irritability, mood swings. They're not always going to be vomiting, shaking, sweating, dilated pupils. You're going to see some of the psychological withdrawals as well. So we want to gather that information right off at the beginning during this dimension, because granted, you might not score really high here, but we've got all that data to use in another dimension as well. And then we want to make sure we're following the protocols to get everything that we need. So we want that medical evaluation. So sometimes someone may need a medical evaluation before admission. And all of you have experienced this, where you've had to send a patient out because you know their needs are higher than what we're able to provide. So you're sending them to an ER, or you're sending them to a higher level of care. Treatment planning, very important with Dimension 1, that our medical professionals are giving us the excuse me, the information we need, and they're implementing these assessments, because we want to know what our medical professionals' perception of their withdrawal and what they're going to need in the treatment planning process, especially with medications, but they may even have some other things that may help you. They may help provide some educational services, especially with withdrawal medications. They may be the person who's actually speaking to their PCP and physician. It may not be our clinicians that are doing that. It could be the medical provider. They are also invested in getting this patient to the next level of care. So that collaboration with that outside physician or incoming treatment center may be a conversation that our physicians are having. Now, with the rating scales here, these are very important when you're looking at them because this is where you're getting the hard evidence-based criterion that speaks the ASAM language and is going to speak your payer's language. So remember, minimum of level 4, a risk rating level 4. If you are an acute care or a standalone hospital with medical and able to provide IVs, able to manage seizures, you are going to pick this level of care. If you're not, let's say you're residential detox, so you're only 3.7 or 3.5, you will pick these two. Maybe you have bio, maybe you don't have bio. The rating for you at the facility, you're staying at 3.7. The rating we're giving the payer is going to be either 3B or 3A. So we're going to need you to kind of know this is meaning we're going to have a lot of medical intervention. This is meaning that we may not. So then I know that many of you have heard, oh, well, you haven't had any medication interventions. So I think we're ready for the next level of care. Well, we weren't expecting that yet. We were expecting to be slower with the biomedical interventions or no biomedical interventions because patients can say no to meds. I mean, believe it or not, they have the right to say no. I need to do this naturally, or I need to do this way or my way. So we want to make sure we're following that. If we are picking 3.7 bio, make sure that this is more going to be perhaps acute care or attached to a medical hospital, because with the bio, we are going to also still need the IV medications. With the non-bio, we're going to have the medication interventions, but we're not going to have the physiological, like the IV bags for dehydration, injections. We may not always have those at the residential detox level. So you may be a residential detox attached to a medical hospital to be able to provide that. So for level 2.7, you have mild symptoms, you need medically managed detox, or medically managed detox isn't really needed, so we're going to that 2.7 level of care. So these are mild, these are more severe withdrawal symptoms for us, and you need that 24-hour care. Any level of care, so let's say we don't need residential detox. We don't really meet criteria for 2.7, but we know this person's going to need the high intensity. So we know we're going to need 3.5. So we're going to pick any level of care, meaning any rating at this point, because we may not have a whole lot of physiological symptoms to worry about, but we know we have some psychological symptoms. And maybe they have no issues. We're going to pick risk rating 0, because right now, risk rating 0, you're either looking at a 3.5 short stay or we're going straight into outpatient with that. Same thing with this. So remember, with the rating score of 4, you're looking at needing immediate medical attention. Rating score of 3.7 bio, so 3A or 3B, you have severe symptoms. You do need a higher level of care because you may need some IV interventions. You need access to medical doctors that have access to IVs or injections to keep you stable. Here, 3.7 non-bio is going to be that residential detox. So we've got access to physicians, we have access to psychiatric care. We are going to work with you on this. You still need 24-hour supervision to get you to the next level of care. There you have that. And then 2.7, again, we still need the nursing care. We need daytime medical care, but we don't need 24 hours level of care. And then the 1.7 is you need medically managed outpatient withdrawal, but you don't need the 24-hour supervision, or maybe you don't want it. So we're gonna refer them to a 2.7 or 1.7 level of care. Prompt evaluation, maybe everything's kind of confusing. Perhaps you don't know how well this person is doing. They may be verbally presenting well, but you can see the blotchy skin, the dilated pupils, the racing heart. Perhaps they're on something else that our UDS didn't pick up on. We may need an eval. So we may say, hey, this patient needs to be seen by the doctor pretty much immediately. And that's what you're doing. You're saying prompt eval, we need this kind of right away because we know this person has needs, they have symptoms, but we don't quite know what's going on. And it's okay to say that. We're going to do the H&P ASAP. And then the addiction medicines, what we're doing here is you've got minimal level 3.7. So we need medical, we need medication, and we do need 24-hour nursing care. With B, you've got daily medical care, but not necessarily 24-hour medical care or, or nursing care, but you do need daytime nursing care. And then 1.7 is that outpatient. And then if we need MOUD, we're going to click that because they're going to stay here, probably at a residential detox until the doctor can see them. And then any level, we just don't really know where they're going. So we know that we may need residential or PHP, but so we can put any in there because they don't have them. Dimension 2, the biomedical considerations and their subdimensions. So the subdimensions are going to be that physical health information and pregnancy-related concerns. Only if you're a biological female are we going to be testing for this because this is going to impede or impact your treatment. And then sleep problems. Sleep problems, we all know if we're not sleeping well, we can't feel better. Your brain, your organs need sleep to reset. They need to regenerate. With these subdimensions, we're looking at, does the patient require medical management of their physical health symptoms? Are they diabetic and is it stable? Are they just out of a chronic health condition and it's unmanaged? Or maybe they recently had a surgery and nothing is managed. Or maybe they have chronic pain that needs pain management and they have not been medication compliant. And if we can get them medication compliant, we know that we will see everything else fall into place in the continuum of care. So this is what we're assessing here. Do they require integrated care? Maybe they don't, but most likely they do. Does the person need a referral to an external provider? Perhaps this person has a head injury. Perhaps they have never seen a cardiologist, but you have discovered that there's something not right with their blood pressure. You're trying your best to management while you're in-house, but we're going to refer them to a cardiologist upon discharge. And if we're keeping them at 3.5, 3.7 or 3.5 or 4.0, and they go to a cardiologist, remember you're sending someone with them because they're still requiring that 24-hour care. Pregnancy test. So depending on your facility and the physicians that you have, you may not admit someone who's pregnant past a certain time period to your facility, and you may. Outpatient wise, there's probably not going to be many issues except for that coordination of care to make sure that your client is getting the care that they need. Are there any complications? Are there any patient concerns with the pregnancy? And what are the risk factors? So how healthy is the woman who is pregnant? How responsive to treatment, what can you do with that treatment, and how healthy is that baby? So you're taking on the responsibility of both those patients. So you're kind of seeing them as a whole and you're assessing things at this level of care. Now with sleep problems, we want to know, what is the impact? What's happening? Are you just never sleeping? Are you having trouble falling asleep? Do you fall asleep perfectly fine but wake up in the middle of the night? What are the causes of those sleep problems? Maybe you have an infant and you can't sleep. Maybe Um, you have a lot of psychological issues that kind of have racing thoughts at night that keep you from sleeping. So we know we've got to provide some biological, or psychological and maybe biological interventions to help you sleep. So this would be the biological interventions. And what is the impact on these sleep issues on your recovery? And it could just be that you're waking up from nightmares every day or dreams of using, and you've got intense fear. You've got some trauma. So we do need to dig into that, learn what's causing it, and try to provide as many interventions to improve your sleep pattern while you're under our care. Um, so in treatment planning, of course, we still use our medical professionals' input here. Um, and they're all going to have that H&P. What providers do we need? How engage, what level of engagement are we going to get to them while we're here? So are we going to transport them to a gynecologist if they're pregnant? Are we going to transfer them to a cardiologist? Or are we just going to make those appointments post-discharge? So you've got to figure that out, and that's part of that treatment plan. What are we doing with that? With the biomedical conditions, in our dimensional ratings for the health concerns, we're going to still follow the same pattern when we're looking at risk rating 4. Acute and severe symptoms that require 24-hour and immediate medical attention. The 3.7 bio, we still have moderate to severe symptoms. We may need, again, IV medication. So we may be sending them to a different facility. This would be our residential detox that we are going to have medication management, but we're not going to have any interventions, intravenous interventions. They're still moderately to severe needs. They need the 24-hour supervision. And so we're doing that rating. When you rate at risk rating 2, you're looking at 2.7. Pretty much anywhere between 2 to 2.7, but you're pretty much going to be looking at 2.7 if they're coming to it at a facility level. And this is daily medical care, daytime nursing care, but not overnight, not 24-hour care. And the 1.7 is that medically managed outpatient. If you know you don't have enough to meet here or here, and you don't necessarily want them and they're not ready and you don't think they're ready for an outpatient type setting, you can pick any level of care because we're moving towards gathering more evidence to prove that they may need that 3.5 or even 3.7. No specific needs, if you have a trend of no specific needs, you're moving to the lower levels of care. So you're starting to look at, as we get into dimension 3, with no needs, to the lower levels of care for sure. Same thing, so the same pattern follows when we're picking these subdimensions that we used in determining these. So it's kind of a routine. So as you get more used to the language and more practice assessing and getting the dimensions correct, you're going to get into that normal practice because we're not using 1 through 5, moderate or severe or mild. We are using those dimensional levels to pick our level of care, which seem more abstract than they are once you get used to the pattern that they utilize at every dimension and subdimension. Okay, so we've got dimension 3, psychiatric and cognitive conditions. Oops, I went too far. And here are the subdimensions, these active psychiatric symptoms, persistent disability, cognitive functioning. And then remember, we're not going to be rating these. I should have kept with the blues and the blacks. With dimension 3, acute psychiatric symptoms. What level of support are they needing? Do they need close monitoring? Do they need supervision? What are they experiencing? And what do we expect that they will begin to continue to experience? And then the persistent impairment. What functional limitations do they have right now due to this? Do they need support? How much support does our staff need to provide to this patient to stay engaged in treatment? Or do they need a higher level of care? What treatment, when we get to treatment planning, what treatment planning options do we need to put? Do they always need prompting? What skills do they possess right now? You could have someone who possesses really good skills, so they're really good at identifying those triggers. They're really good at identifying the coping skills they should utilize, but they're really struggling at application. So you know the difference between um, someone who needs help with identifying triggers and coping skills needs a lot more intervention and support than someone who is just needs to apply those skills. They can identify the triggers, they know what they are, they can identify those coping skills, but they're having that hard time applying them. So there are going to be different levels of support. And then suicidality is an important factor to assess. Um, what is their history? We need to screen upon admission. What are our protocols for determining when you need to transfer? Outpatient client, physician, clinician. When do you know that it's time to call or get a well check or get an assessment from an outside source? So depending on your community, they have mobile crisis teams that will come and assess someone. You also have facilities that are really close to you that you can um, somewhat support your client going there. I'm not saying take them, but somewhat support. So provide, reach out to family, reach out to the mobile crisis units. Dimension 3 treatment planning. So the significant mental health and cognitive issues that we see our patients having will drive our interventions, what we're expecting out of them, and how much support we're going to give to them. So we definitely need to know what those issues are. And those qualified professionals are going to be the clinicians, the psychiatrists, and even your nurses. And believe it or not, your BHTs, because they're going to be with them a lot. So you'll get a lot of information. Maybe not at the initial assessment, but as you do ongoing assessments. The relationship between that physical mind and body are connected. The relationship between substance use or the discontinuation as it interacts with their mental health symptoms. And then what support services are we going to need? Maybe this person is going to be an individual that you're going to keep through all the continuum of care. But once we get to outpatient, we've got to send those patients out. So we're going to start working on those providers, or maybe they've seen someone already and we want to speak to those outpatient providers for sure. Trauma-related needs. What are we doing here? What is their exposure? I know that I've spoken to clinicians and they're really afraid to touch base here because they know they don't have enough time to peel off all the onions and provide the best interventions. But you do need to know what that is. When you ask the question, if your client is saying, oh, I don't want to talk about it, then it is deeply rooted. There's a lot of trauma that can give you some insight to how you're going to treat this patient and what interventions this person may need. Because it is really traumatic if they can't even bring it up, if they don't want to talk about it. And it could be at the first session that they're not ready, but then as they get comfortable and talk to you or they're in group, they may start speaking and they may things start kind of spilling out. That they're ready, what they're ready to talk about. That full psychiatric and cognitive history, we want to know what their past diagnoses are. So this is a good reason to reach out to their outpatient clinician because you get those diagnoses, you get a glimpse of the history, you get a lot of this from collateral with families, but you also get this from the patient as well. And then what symptoms are they experiencing now? What role does substance abuse actually play in their lives? So remember, when we're talking about behaviorism, the use of a substance, there is a purpose for that. What are they avoiding or working towards? So we want to know what that role is, and that's a good question to ask. Some patients and clients don't know, but that's for you to help them unveil and get there. And then their treatment history and their responsiveness to treatment throughout that history. So with our subdimensions for active psychiatric symptoms, the same pattern will follow, but you'll see we have co-occurring instead of the biomedical, the bio kind of specifier. You can pick 3.7 co-occurring or just 3.7. But 3B is we know if we are meeting some criteria here, it's intertwined. We're not just working on rehabilitation from a substance. We already have those psychological symptoms there, so we can pick it. The 3.5 is the residential. So again, 24-hour supervision, 24-hour supervision. But if you're meeting at level 4, you've already met at level 4 at dimension 1 and 2, or 1 or 2, and you're needing that higher level of care. Dimension 1 or 2 may have been um, assessed at any level of care, and you're meeting here. Same thing if you're meeting for the medically managed intensive outpatient, high intensity outpatient, or your IOPs. If you have no needs, people coming to us, outpatient, you may not have any, you may see some risk ratings of 0. I highly doubt that you're going to see some risk ratings of 0, but you might upon your initial assessment, but you're going to need that biopsychosocial and that extra meeting to make sure you're getting that information, because it's not likely that someone is reaching out for treatment and they don't have any psychiatric symptoms. They just may not be aware of them. So they're not really ready to discuss them in there. And then that persistent disability. We know that if we have cognitive impairments, but we are flexible, we need individualized outpatient, we're going to pick this. But if we have cognitive impairments and we are requiring treatment support, we want to pick any level. And again, the 0 is not something we're going to be going through. With dimension 4, so these substance abuse related risk factors, what are the likelihood that behaviors are they engaging in due to risky substance abuse? So what are those risky behaviors that they're engaging in due to their substance behaviors as well? So am I using and going to work? Am I using and driving my kids to practice, or am I showing up to practice, or am I showing up to their schools? Am I engaging in illegal behaviors? Have I tried to buy substances, or engaging in sexual risky behaviors? What are those related behaviors that are exacerbated or even started because I'm using my substance? And then what is the level of associated risk? And that risk can be adverse medical or emotional or social. And I kind of go into it a little deeper in one slide. But serious harm, like, are those behaviors that I'm engaging, could that cost me my life? Or could it cost someone else their life? My behavior in substance use, could I have an overdose? Could I move into liver failure? Many of us have had a client who is at stage 4 liver damage, and they continue to use, and we know we're desperate when we're working with them to get them to stop using, to get this treatment episode to work, to get them there. COPD, any respiratory issues can be exacerbated from our substance use, as well as any other chronic health issue. But cardiac arrest is a big one. My use, is it going to cause me to have a heart attack? Am I risking my children? Am I neglecting them, or are they in danger? Am I driving with them in the car? Or am I putting myself in dangerous situations where I could be a victim again of exploitation, sexual abuse, physical abuse? We want to assess those levels of harm. How harmful is me getting high today going to affect the entire scope of who I am? And the destabilizing loss. So the losses that can occur due to my substance use. Am I at risk of losing my relationship? Am I at risk of losing custody of my children? Am I at risk of losing my job? A lot of jobs now have some supports that help you go into treatment, and you've got the FMLA that helps support that. But have I utilized that, and have I burnt that bridge? I'm going to need my job because I need to pay my bills. I definitely want to keep my health insurance. So what is my risk there or my patient's risk? And then risk of freedom. Am I on my third DWI? I did read, and I'm not sure, there are some states that are moving to one DWI and you're serving time and required to go into treatment. Am I risking my freedom? Is my substance use affecting the spheres of my life, job, academic, relationships, health, employment? Those are the things that would rate this as destabilizing. Am I risking any of these things? And then what is the expected time frame that you will experience this loss? Or you could get better without intervention. And typically, without intervention, you're not getting better because it's very difficult if you've already tried to do it independently. So we are assessing what is the time frame that you could lose your job in a week if you don't quit. Your wife or your significant other, your husband is going to leave you. Your parents are going to kick you out. So what are those relationship risks? And then what is the likely response to this loss? So loss isn't just the only thing we're assessing. What is your reaction going to be? Are you going to spiral down into a deep depression? Are you going to use heavier? Are you going to live on the streets and start putting yourself in more of a position to lose everything and then deep into that depression? So we want to assess that and utilize that in assessing this dimension. Judgment of risk. I may be sleeping with 25 people a day and not think that's a problem. That's a problem. My assessment of the risky behavior. I drove to work today. I've had 3 beers. I only had 3. But I'm not telling you that, well, any beers is probably a problem while I'm driving, but I also had more. I'm not really being forthcoming with my information. So what is my judgment, the client, and then also what is the clinician's judgment of their risky behavior? Do they even feel that their substance use is a problem? Are they aware of the triggers and what causes them to use? What is their access to substance use and their ability to cope with stressors and cravings? Cravings can last up to years after a successful rehabilitation treatment episode. And those coping skills are what help you manage that throughout that time. And you could go years without them, and then one trigger, one major loss can bring it forward. And you being able to recognize the trigger, know the coping skills, and apply those coping skills are what keeps you in that sobriety. And that's easier said than done. And we've all been working in this field, so we know. All right, so substance Dimension 4, the related risks. So we're determining the risk related to substance use and their behaviors. We're identifying the need for their supervision. And then what is the clinical service intensity needed to help them gain insight, help them build their skills, and stay sober? What does this client need for this treatment episode to be successful and maintain? So in treatment planning, we are looking at their strengths. We're looking at their challenges. We're looking at their full substance abuse. We're looking at their history to drive the treatment plan level. So how intense are we working on identifying those triggers? How intense are we working with the client and maybe their family so they're not at risk for that loss? And what insights do we need to help them gain? So what interventions do we need to provide so that they start understanding the risk of their behavior and the gravity of it and start to actually learn something and apply and reduce harm to themselves? So same thing here when we're rating, only you see we don't start as high. We don't look at 3.7 and we're not starting at 4. We're starting at 3.5. So we're starting at residential. Rating E, it's just what that level is rated. It means we do need that 24-hour clinical and medical supervision. We need time to develop our recovery skills, so we're going to be at level 3.5. 3.1 is that RRS, so we have 24-hour clinical care, but not medical care. We need to sustain or develop those recovery skills, and not all states will have access to 3.1. 2.5 is that PHP. We need daily clinical and medical intervention and psychological support, but we don't need the 24-hour supervision or supports. And then, of course, the intensive outpatient is going to be the 2.1, and then outpatient is an outpatient referral for 1.5. Same follow pattern here. But here you can have a no specific needs and risky behavior, those risky related behaviors. I may not be engaging besides the substance abuse in anything, and I may not be at risk of losing anything yet. So I may see no specific needs in this area. Dimension 5, we're almost to a close. We're at the end of our track. Dimension 5 and their subdivisions, recovery environment. I didn't type that in there, so I apologize, but we're looking at our recovery environment in Dimension 5. The ability to function effectively in our current environment, the safety of that current environment, the supports we have in our environment, and then the cultural perceptions of substance use and addiction. Interesting enough, you've all probably encountered a patient. When I talk about culture, I'm not just talking about like ethnicity or region where you live. We're looking at the culture within your family. Many family members will support their family member coming to treatment, but then they don't remove alcohol from their home. They don't change their behaviors. They don't realize that they want their family member to get better, but their behaviors have to change as well. So we're assessing that. The goals of this dimension is identifying the clinical needs and the intensity of the services, the supports that they need while they're in your facility or while they're under your care outpatient wise, and when they're done with you, the stability of that, and identifying their needs. Maybe they don't have a safe environment. Maybe that's something you're going to work on together. It could come in the form of stepping down to a level of care with housing. It could be sober living. It could be living with a sober friend. It could be something. We want to also assess how able are they, how effectively are they functioning? Does this patient need rehabilitative services to learn the basic interpersonal skills and skills for independent living? So maybe they've never lived on their own, or maybe they've been so removed from socialization while they're using the substances that they need help re-engaging. They need help. Even with basic skills like bathing, brushing your teeth, those are supports that they may need. Does the person need their supportive environment to practice these skills? You will see some daily living facilities have like bathrooms and kitchens where they practice these skills. So some people will kind of engage in those environments as well. What is their social network, school environments, and work environment? So you're looking at all of that in their environment and how it impacts their current treatment and their recovery. And then we kind of talked about social, interpersonal, and skills. The safety and support, we do really need to ask those hard questions. I know it's difficult, but are you at risk for abuse? Do you feel like the people you live with have your best interest? And sometimes we say no, we don't think they have our best interest, but there is no major abuse. And then sometimes there is, and they don't recognize it. So having the conversations to learn, is this an exploited person? Is this a person who is only using because their significant others pressuring them, or all their friends are pressuring them? Do they have a safe home to go to, or are they going right back to this homeless shack where tons of people are going to be using? So is it going to be sufficient for them to maintain their recovery post-discharge? And building those daily routines are very important. So believe it or not, the prompting helps by saying, hey, it's time to get up. Hey, it's time to brush your teeth, wash your face. It's time for breakfast. We humans are social beings, but we're also creatures of habit. We do thrive off of patterns and routines. It helps provide a stable foundation. Sometimes we sway from them. Some of us are really good and flexible, and others aren't. But those routines and structure help in, you may not believe this, but some of the people that you work with have never had a routine or a structure because their environments have never been safe for them, or they're so abusive, it's too hard to maintain a structure or a routine. Conflict resolution skills. Can they argue effectively with their significant other? Can they argue and listen? So can it be a productive, constructive disagreement or challenge of something without a huge argument or a physical fight? So those are things we need to look at with the client as well as their recovery environment. And then, believe it or not, openness to change. So if we look at Costa McCrae's ocean personality traits, this cooperative, openness to others, listening, being flexible are all important skills that we may need to help our clients build or strengthen or even be exposed to. And then we want to look at parenting skills and financial skills because we don't want them to leave with not able to manage their 3 kids at home, or we want to be able to see what resources or what community supports this person may need for food, for electric bills, stuff like that. So here's that services and supports needed for safety, and then building that support system. A lot of people believe that asking for help is a sign of weakness. Asking for help is probably the biggest strength that we can all have because we all need help at some point or time. And then the way we pay that back is by helping someone when we feel stable and secure and safe. It's a cycle, and our support system needs it and we need it. So when we talk about treatment planning, patients here you might find start talking about the trauma as we get into the deeper alliance. So when you're treatment planning for Dimension 5, you might start hearing stuff. They may not have wanted to have that conversation in the middle of that biopsychosocial, but now we're talking about their environment and they start talking about, well, my mom does this, or my dad does this, or my significant other does this, or my friends do this. And then you start picking up the pieces, the breadcrumbs to understanding or unveiling what their trauma is. And then you also build that rapport with your patient. That is very important for their recovery. And then we want to make sure we're considering their permanent need for support. I feel like a broken record, like permanent supportive housing is so important. A recovery residence services. You have all sent someone to a sober living where they do have psychological and outpatient or IOP or IHOP services. We want to do that. And then the cultural support. It's very difficult. I know that many people have individuals who may be here alone from maybe they're on a different side of the country than all their normal routines, or they're in a totally different country. So understanding what cultural supports that they need is important in helping maintain that recovery. If you have someone of a certain, let's say, Muslim religion, yet they're here, they're kind of feeling detached from their culture and their environment, you might help them reach out while they're in care to a Muslim community center, Muslim religious entity, to start connections with those supports. That will help so much in the right time and place. All right, so the treatment planning support. What are the obstacles to treatment or recovery? We need to make mention of their environment. What are we planning for post-discharge? This can be in your discharge planning section. You are working towards sober living, you're working towards PHP with housing, you're working toward those family sessions to build up those supports. And you're looking at all of these things to help build a foundation. We all have a foundation that helps maintain us when we are stressed. We all get stressed. We all forget to use our coping skills in different scenarios, but that foundation is what helps us maintain feeling safe, feeling secure, and opening up. So we want to help build that for our clients. The rating scale for Dimension 5, same kind of thing where we start at 3.5. So we're still needing the medical substance abuse or mental health support. We have daily functional impairments that we need to work on, skills we need to build. So we're going to rate for rating D. 3.1, that is still, again, that RS environment. So they don't need 24-hour care. They don't need, well, they need 24-hour substance abuse and mental health care, but not medical care. And so they get those supports in the residential environments. 2.5, our HIOP. Again, we still need the medical, the psychological supports, but we don't need 24-hour care, and we're going to practice those skills. So we're going to use that. And then 2.1 is our IOP. Risk rating any can be any level of care, but again, we're already at Dimension 5. If you're picking any level of care and you know you need one of these, you don't want to pick that one. This one would be something lower, like I know this person needs outpatient care, so we're going to pick that one. The safety in their current environment, it's just two. Either there's no problems or there is a problem. So you're going to pick either one of those. The supports in the current environment, 3.1, that is that needing 24-hour mental health and substance abuse care, but not necessarily medical. So it's that recovery residence that we're looking at, or even just a recovery residence. Maybe I need sober living. Any level of care, maybe I just need outpatient, and then no specific needs. We finally made it to Dimension 6. There are person-centered considerations, and this is where you're asking the patient, what do you think you need? Also, after meeting with you, going through the dimensions, this is what I feel you need, and this is what the ASAM criteria is supporting. What do you feel about that? They could still say, I want detox. We need to use some motivational interviewing to get them to accept what level of care they do meet. And if they still say, I think I need this, then you need to ask why. Because remember, you can get through this entire assessment and your patient still hasn't been forthcoming or has forgotten that perhaps you think they accidentally OD'd 6 months ago, but really they were trying to kill themselves and they purposely meant it, and it doesn't come out until here. So that's where you've got to gather that information. And then we want to get their input on their treatment planning and their aftercare. What do they see the plan for them? What do they feel like they need to work on? What are their concerns? What do they think their supports that they need? And what are the barriers for discharge? Those barriers for discharge can be housing, can be access to medical care, access to medication. It can be financial distress, academic distress. It can be their family, and we need to dig out why and what's happening. You don't have a rating for Dimension 6, but you do utilize this to help you come to the overall rating. So when you're getting your level of care recommendations, I should have given you a slide on the whole, but I didn't. So I'll add that in at the end when you have that. But basically the overall rating is where you're gonna either pick residential 3.7, 3.5, or an RRS, or level 2, or a level 1 at the end, and kind of give them their support. We do, like I said, you're using that dimension 1 through 5 to contribute, and then the dimension 6 goals is assessing their ability. What do they think they can do? What do they feel like they're capable of doing? What are their fears? What are their preferences? Helping them identify those triggers. What are they ready to build? You can have a readiness for change at each dimension, and you can discuss that here as well, but it's going to be not just a stage of change. You can talk about it at each dimension. So I did forget to mention that. Here's another pictorial of that patient's journey to end us with. We're doing that level of assessment criterion here. We do the dimensional criteria, we figure out what continuum of care we want to be in, and then we start our planning and our treatment. And it's a cycle until they're ready for the next level of care. Let's see, did we go over, Callie? Oh, we're at 1 minute. Let me stop sharing and see if I can. Do we
You
have
did
time for
great.
questions? Or should I can go through them and answer you guys?
Yeah, we do have quite a few, so many good questions. If
Okay.
we want, I can actually I can save them, and then
Okay,
Audrey, if you want to just maybe answer them, we can put them in the follow-up email,
perfect. I will do
you
that.
know?
Mhm.
Yeah, let me make sure I get all those saved. And again, we're back February 27th. So hopefully we'll see you all again next month. Your CEs are going to come to you from CE Go. You'll get your eval in your email, the same place that you joined the webinar from today. And then once you complete the eval by next Friday, you'll get your certificate sent right back to you.
I forgot your slide. I'm sorry, Callie.
Oh, it's okay. I'll get it next month. All right. Thanks, y'all. Have a great
Thank
weekend.
you,
Stay
everyone. Have a
warm.
great day.